panel is what the real landscape is clinically and what the challenges are to treating patients now, understanding them, as well as where can we go, what can we do as an institution at MIT to bring more science into better diagnosis and better therapies for these diseases. And to set the stage, I'll just mention that when Dr. Isaacson and I started the Center for Gynepathology Research in 2009, we were all excited, and immediately, almost after that, I was diagnosed with triple-negative breast cancer, a very aggressive form of breast cancer with a big supersized chemotherapy, radiation, and blah, blah, blah. It was a really, really tough year, but it was comforting that there were so many clinical studies guiding my care, the decision-making. I had amazing doctors, and I had amazing support at MIT. I got an extra term off from teaching to recover from chemo. People brought me food. They, did all kind of stuff, a lot of sympathy. So my experience with breast cancer was really a walk in the park compared to the 30 years of being an endometriosis patient, when instead of sympathy, I had an emergency hysterectomy in the middle of fall term. People were taking a class I was teaching. They needed to graduate, so I was back teaching a week later. And so we really don't appreciate the incredible toll this takes on women in the community, and we can, as a community, come together. So what we want to do now is really delve more into the clinical landscape and realities, as well as the science and what we can do. And so Shannon Cohn and I are going to have a little conversation here with our panel, and we've chosen for the panel some really amazing, diverse experts, including 3 local surgeons. All of them are what would be called in the movie excision surgeons. Dr. Isaacson at Newton Wellesley is the past president of the American Association of Gynecologic Laparoscopists and trains other surgeons in how to do this kind of surgery, and 2 of his former fellows who are out in clinical practice at diverse kinds of practices, have seen a lot of different kinds of patients. Dr. Naya Noel at Boston Medical Center, and Peter Movilla, who's been around in Kentucky and is now back in the Boston area, have seen a lot of different kinds of patients. We have the incoming president of the World Endometriosis Society, Dr. Stacy Mismer, here from MSU. She is the senior author on some of the first genome-wide association studies for endometriosis, fabulously recognized epidemiologist in many of the consequences of endometriosis across the lifespan. We have Professor Chris Boble from UMass, who's an expert in menstruation issues and society and stigma attached to a lot of these gynecology diseases. Alicia Carlson-Bryan is here from MIT's pre-med advising. I've worked with her for over a decade, and she as a patient, is about to have her second baby, but has experienced a lot of the healthcare so much she went back and got a PhD in healthcare professions education because of the thing mentioned in the movie about the horrible lack of understanding. And a colleague, Dr. Tavneet Suri from the Sloan School, she is an expert in economics and especially poverty in Africa, but also as a patient has an astounding, how can it be that we are here with the best access to medical care, yet we're still unable to get past the things that really are not well treated. So maybe what we'll start with is, and I think that Shannon did an amazing job of picking a diverse group of patients of different ages, different situations, professions, family situations. But maybe we could start by kind of calibrating with some of the landscape of what you see clinically from the surgeons. And who do you see in practice? Patients come in, they have a variety of different kinds of situations. And what is the clinical heterogeneity in some of these patients? And you might even mention things about other uterine problems, et cetera. So maybe, Naya, we could start with, Dr. Noel, we could start with you. And
yes, I mean, I definitely, so I practice at Boston Medical Center. I'm an assistant professor at the BU School of Medicine. And in my practice, I certainly see a lot of patients with endometriosis. I see a lot of patients as a surgeon trained in minimally invasive GYN. I definitely get a lot of referrals specifically for this condition, having gone to their primary care, having gone to family medicine, and then being referred to after I guess, 7 to 10 years perhaps, unfortunately, to get a diagnosis of endometriosis. And so, yes, patients come in all different presentations, different symptoms. Obviously, the hallmark is painful periods, but pain can occur in a lot of different places in the pelvis, and sometimes that's part of why patients may experience a delay in care, because they might have painful bowel movements, painful urination, painful periods, and sometimes it can be confusing for providers seeing all of these things at once. And it also can sometimes be co-prevalent with a lot of other pelvic conditions, such as uterine fibroids, which I also specialize in, and other painful bladder syndrome as well.
So Keith, maybe you could expand on, some patients do respond to therapies, and some patients have surgery, some patients have one surgery and it's one and done, and others, what's kind of the, you see the kind of clinical landscape of experiences patients might, statistics, rough statistics even on, who responds, who doesn't respond, recurrence, need for additional surgeries even after excision.
Let me first say, Shannon, that was amazing, and congratulations. And I think it's a tremendous benefit for whoever gets to watch this to be made aware of a disease that's so prevalent. So thank you very much. And my second thank you goes to Linda, because I just want to back up a little bit, and I'm going to make a comment about the film and some of the things that may have been perceived in the film before I get to your question, Linda. And that is, I went to Linda in 2009 because Linda was a brilliant engineer in tissue engineering, and we really did not have a way to study endometriosis because there really is no good animal model for endometriosis. So it's present in primates, and it's present in humans, and that's about it. And people try to create models using rodent models and what have you that just were not relevant for this disease, and tried to extrapolate the data saying that it applies to humans where it did not. So because of that, what Linda has done in starting the CGR, that's really our mission. Our mission, and I just want to say as a surgeon, yeah, we do excision surgery, but that's not the answer. And for people to, I don't want people to think, yes, I've gone to an excision surgeon, therefore I'm going to be cured. The answer is trying to understand how it got there, why it got there, how does it behave, and what can we do to not only prevent it but treat it better. Then I take what I call the Neanderthal approach, which is just to either remove or destroy the tissue. So that is obviously a temporary benefit, and you've seen that in the patients, but it's not a cure, as you've also heard. So I think the work that Linda's doing in trying to get funding for this to really understand the disease, we don't understand it any better now than we really did 30 years ago or 40 years ago. And that's where we have to start. And so, again, I want to give kudos to MIT, and it's been an amazing journey for me over the last 10 years working with Linda, because I've learned so much about basic science, and hopefully we've contributed a little bit as far as the clinical. But that's the real relationship that we need if we're going to make progress. So a lot of good things were said on that film, but it's not the answer. I don't want you to think, and unfortunately there are some surgeons who say, I do excision surgery, you should only come to me because therefore you're going to be cured. That is not the case. You want to remove as much disease as possible, and usually excision is the way to do that. Other techniques have been shown to be equally as effective, but the answer is trying to understand the disease. And that's what I want to thank Linda for all the work you've done with the CGR, and presenting to all our national, international GYN societies has really raised the awareness that we need to understand the basic science.
Okay.
What was the original question?
So Keith didn't answer the question, but Stacy's actually published on a lot of this recurrence and is very familiar with the literature. So maybe you could expand what the clinical situation is with recurrences and different therapies and how patients progress through these therapies, et cetera. So, because I know that you recently published a review on this.
Absolutely. So sure, I'll tackle following on Keith's great description that really, and also what Shan's film showed so eloquently and movingly is the varied experiences of these patients. And one of the critical things that we in science and through clinical investigation are trying to bring to endometriosis is that we have more than 400 diseases with rigorously defined, clinically utilized classifications. Those classifications define treatment selection, it defines prognostic expectations. They're utilized by clinicians and scientists all over the world. And we do not have that for endometriosis. And the staging system does not correlate with symptoms. It doesn't correlate with treatment response or prognosis. And so one of the key areas is defining at molecular levels, defining at a clinical patient level, defining with the variation in why do some patients with endometriosis have pain that actually even starts before their first periods? Why do some patients have no pelvic pain but are discovered to have endometriosis when upon infertility? There are women who are found at tubal ligation to have endometriosis and haven't had any of those clinically evident symptoms. So defining that and building the data to find that variation so that we can start to predict what are some of these important etiologic driving recurrence, driving treatment response is really where all of the multidisciplinary energy is focusing.
Okay, we'll come back and pick on you later about the genetics and so forth, but maybe while we're still reflecting on the very powerful stories in the film, Alicia, you could share with us your experience as a patient going through social media, because you relied, as patients did in the movie, on social media, and then had a journey that led you into understanding about multidisciplinary practice, et cetera, and it led you to change your educational, your career vision. Maybe you could just share a little bit about that path through on how you got information yourself in this local Boston community.
Yeah, so I would just say, with social media, it's really important to look at everything with a really critical eye, because there tends to be a very dramatic opinions one way or the other, and so it's important to kind of filter through that. But I would also share that, exactly what Keith is saying, but from a patient experience is excision is not the answer. And I was very fortunate that I had just changed to coming to MIT and found myself in Linda's office about 2 months after having excision surgery. And I just thought I was healing, and that's why I was struggling walking across campus and having to take breaks here and there. And I had no idea who Linda was. I was just doing my job with my pre-med students, and we were just going to, interview them together and provide them with a letter of support for their application. And then I realized, oh, wow, she does research in endometriosis. This is amazing. And wow, she's experienced endometriosis herself. And that's how we got into a conversation. I was like, this is normal, right? I'm just healing, right? And she was like, no, you need to go get checked out. And that's when she connected me with Keith. And then I was quickly diagnosed with pelvic floor dysfunction after having excision surgery and referred to a physical therapist. And with that, I also had pain management and, trigger shot injections to calm things down. And I've done acupuncture and everything. And I'm very fortunate to say thank you to Keith to referring me to a physical therapist instead of just going to another surgery, which I see a lot of patients do. And I was thinking that's the path I was on until I did physical therapy and saw the results of that and was able to just have that one surgery, calm down my symptoms, and now I'm 2 IVF treatments in. I have a 20-month-old, and I'm 7 months pregnant with my second one, and I have Linda to thank for all of that.
You have your own grit and determination to thank for that, and a lot of great clinicians. And I'm grateful to you for getting so many MIT students into medical school, because they're going to become gynecologists next, as we know. Today, I know I arranged a conference room for Dr. Peter Mervilla to organize a conference around multidisciplinary with radiologists and other clinical practice. So maybe, Peter, you could give us a little picture of how, going into the future, you and others can answer too, you're trying to bring in other clinical specialties. So Alicia praised the multidisciplinary nature, that there's pelvic pain, there can be a lot of things going on, and pelvic floor dysfunction, and it can be really complicated to figure all that out, and patients can have endometriosis all over the place. And how do you get other practices to work with you?
Yeah, well, again, thank you guys. Thank you guys for hosting. This is the third time I watched the documentary. Every time I feel like I gained something else, so thank you. Alluding to your question, one thing I'm in charge of at New Wellesley Hospital as one of the gynecologic surgeons is to try to get people to the operating room when they meet that aspect of care, meaning they've tried other things, to do it safely. They alluded to it once during the documentary that the surgery isn't something that all OB-GYNs do when it needs to be done, and it can be quite complex. So I was able to get great training from Dr. Isaacson, as well as Dr. Noel had as well. And the training has allowed me to provide a skill set to patients when they need it and when they feel that surgery, which is a drastic option if you think about it, to just even diagnose something and to do it is needed. So kind of through some networks that we have in Boston, because we're a part of this huge healthcare network with Mass General, Brigham, we're able to kind of get people to buy into the idea that people actually have pain. And it's not just on their ovaries or their uterus, but it can be on their bowel and their bladder. And when we need to do surgery, how can we try to predict that before we go into someone's belly? So we don't just go in and go, this could be a scary surgery. Because every time you do surgery, you can incur some type of risk to patients. And these are young patients. They're in their 20s to their 40s at times. And if you cut into their bowel and there's a complication, that can lead to a decreased quality of life, which is ironically what we're trying to improve. So one thing I've been given the access through the program I work at is to work with amazing radiologists who are at the forefront internationally, trying to preoperatively predict it with MRI and some other trials that they're looking at to try to diagnose it with other imaging modalities. With colorectal surgeons who focus so much on colorectal cancer, but now have shifted some of their time to work on endometriosis, because that's not something in their advanced surgical training they actually even heard of. That's a very common thing I hear, is that they didn't even know endometriosis could be this bad. And when I get involved in some of the stage 4 cases, they're shocked how complex it can be, very similar to diseases that they see with something called inflammatory bowel disease. So, I became a surgeon in women's health because I wanted to help people in some of the most intimate aspects of their lives. But as Dr. Isaacson kind of alluded to in the documentary alluded to, there's only so much we can do as surgeons. And as doctors, we really are kind of limited by our tools and kind of our knowledge of the disease and what to do after surgery, for instance. And it's one reason why I'm kind of inspired that this room is here. How many of you guys are students by raise of hands? A lot. And I myself was an engineering student, so this platform is amazing. You may not even know the downstream effects. I sat in a room just like this and inspired me to become a doctor. But if you want to become a doctor, great. But I say we need more scientists and more engineers who even know what this disease is, because I didn't even know about it until I was a resident in OB-GYN. And I had some pretty advanced education in healthcare beforehand as a biomedical engineer. So I hope that this inspires you and you're already advanced from most other engineers and scientists even knowing about the disease, so you can help us diagnose this early, treat this, hopefully before surgery, and then help us out, not just with the surgical tools like that differential robot that you saw, but also what to do after surgery. So I just implore you guys to, hopefully target your career like Dr. Griffith has.
Well, I encourage all the students. MIT could potentially start an initiative in women's health, not just gynecology. We're here today watching an endometriosis movie, but a lot of diseases skew strongly female, and they're underfunded by NIH severely. There's a huge funding gap for women's diseases in general, and that leads to a health gap, which may be contributing to the wage gap we hear about so frequently. So MIT students, when you make noise, you get heard, so we can continue to have these discussions long after tonight, and we'll continue. So what I'd like to do is continue a little bit more on the science, and then I want to come to some of the more societal things and bring in Chris and Tavneet and so on. But let's finish up a few of the scientific topics, because I think a lot of people here will be wondering, can I do something, and what's the landscape? And one of the things we hear about a lot is genetics, and we sit here in the shadow of the Broad, and it keeps getting bigger, so the shadow, we see no sunlight anymore because of the giant floors added to the top of it or whatever. And so, is genetics the answer? What have we learned so far from genetic studies, and are there new cures on the horizon from things we've learned? Soon.
It's an excellent question. And, full disclosure, we have samples at the Broad being genotyped right now.
Of course, everybody does, don't they?
But so the genetic landscape has been really interesting in that so far there has not been the emergence of a rare but high penetrance BRCA1, BRCA2 kind of a gene. We're now at the point where we're explaining about 5 to 6% of variants of endometriosis looking at GWAS studies. And the next phase that we're focusing on is, again, this sort of subphenotyping and taking into account whether we can find genes that are associated with specific combinations of pain profile and treatment response and the visualized disease. The tricky part has been that, again, because endometriosis has been largely ignored and underfocused on or underfunded, that most of the large genetic databases, most of the large genetic data that exists that are combined for looking at many other conditions just don't include endometriosis data. And so Karina Zondervan from Oxford has led an international team that has now pooled together over 25 data sets that now have 70,000 endometriosis cases and almost close to 1 million controls. However, when we then try to pull in those detailed phenotypic data, the pain variation, the visualized disease, we get back down to 6,500 cases. And so while that's not nothing in a genomic discovery world, you're starting to get smaller and smaller. And so, again, AI and looking for novel treatments. Another thing that has come up is that looking for genes that predict novel pathways outside of hormonal pathways and hormonal treatments. I know there are people in the room who have vascular biology expertise, proteomic expertise, metabolomic expertise, pain mechanism pathway expertise, and bringing in novel understanding, certainly inflammation, inflammatory markers is the next step for that, both genetic and omics discovery, but the key is we're just building the data sets now.
Everybody's bringing up pain, 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 pain. This is what brings most of the patients in. Some come in for infertility. What do you guys, who are clinicians, learn in medical school about managing the pain, putting metrics on the pain? How do you judge the pain? How do you judge if a patient has responded to the pain? And how do you see interacting with scientists to assess whether patients have successfully recovered from pain? So what do you learn in medical school? And
Long time since I was in medical.
but
I forgot everything.
no, but
I
you see
forgot
the
everything.
no, you don't.
But what I want to say about the pain, this is the endometriosis. As you've heard, the reason to treat it is the way it affects the quality of your life. And so as far as we know, it doesn't necessarily develop into a cancer or a precancer, number one. Number two, it doesn't even progress in 75% of patients. It will get to a certain stage and remain at that stage. So,
And what
but the fact, so one of the things that was mentioned in the movie that I'm not sure I agree with is that diagnosing it early doesn't necessarily prevent problems 20 years down the line, because it's not only in 25% of the people will it be a progressive disease, and actually in 25% of people it regresses by itself. So you want to treat it because of the way it's affecting the quality of the life that day. If it's affecting your fertility that day, you treat it. I'm not treating it now because I'm trying to help fertility 10 years from now. Most people present with pain. 80% present with severely painful periods. Severely painful periods most likely is due to uterine disease, which is adenomyosis, which as far as being underdiagnosed is grossly underdiagnosed, because when you look with a laparoscope and you're doing surgery, you can't see adenomyosis. Adenomyosis, by definition, is in the muscle of the uterus, and you're only seeing the outside. So what happens is you see these little lesions poking here and there, and you excise them, and you say, I treated the disease, but you probably missed all the diseases causing the symptom of painful periods, because it's in the muscle of the uterus. So fortunately, in the last 5 years, or maybe 6 or 7 years now, by ultrasound and MRI, we're much better at diagnosing adenomyosis, and now we're seeing that. I've seen it in patients as young as 12, or as young as 13 and 14 years old. Now I know why they're missing, 1 or 2 days a month for school because of the pain. It's not because of their stage 1 endometriosis outside the uterus. It's because they have it in the muscle of the uterus. And it's no one's fault. We didn't know it was there. It's not that we weren't taught about pain. We just couldn't find it. So it's been one of the recent advances that now we can find it, and now we can address it better. And hysterectomy is obviously not the answer. You're not going to even suggest taking out someone's uterus when they're 13, 14, 15, 16 years old. So we have to offer the best treatment short of a hysterectomy. And surgery is not even the answer for most of those patients. It has to be some type of medication and suppression for now until we find a better.
Yeah, so we'll come back to the pain, because I think Keith brings up a really excellent point about adenomyosis being underdiagnosed. And I'll just add a statistic I often use in talks. If we look at PubMed as an integrator of research intensity across all sectors of the world, industry, academia, et cetera, if you look at a disease, Crohn's disease, which in the US has about a 1% of people suffer from Crohn's, which is a terrible disease. There's about 60,000 citations on PubMed right now this month. If you look for publications on adenomyosis, we don't even really completely know the statistics, and Stacy has recently published on trying to estimate them. But it's probably around at least 10%, and again, it could be the actual cause of symptoms in patients who think they have endometriosis or may have stage 1, which 70% of patients have just very superficial disease, stage 1, 2, yet a lot of pain, a lot of symptoms, not minimizing. Stage 1 is this weird psychological thing, because it doesn't mean that your symptoms are at stage 1. Your symptoms could be level 10. But adenomyosis, there's only 3,000 publications. So it affects maybe 10% of women post-menarche. So maybe 2 to 3% of the whole population in the United States, only 3,000 publications, okay? 5% of the research intensity of Crohn's. It's not diminishing Crohn's as a terrible disease, but it's hard to know how to treat adenomyosis. So you have a patient who has it, it's hard to know how to treat it if you don't have the clinical experience, the data, and so on. So there are people in this room who I know have family members suffering from adenomyosis, and we have started to study this in the lab. It is amazingly aggressive, and this is one of the things that we can together at MIT start to reveal. How is it like, carcinoma doesn't even really invade muscle this way. So there's some fascinating things for the research community around here. So I'm very glad you brought up the adenomyosis. But I want to Stacy.
And I'll just add that of those 3,000 papers, the vast majority are in tissues and symptoms of those who've had a hysterectomy. So as Keith was describing, we know very, very little about the experience of adenomyosis in adolescents, young women, and we know very little about molecular signatures and everything else that you would like to know absent of hysterectomy. So for example, thinking as an epidemiologist, we see things like women who have greater parity are more likely to be diagnosed with adenomyosis, but that's in a hysterectomy population. And so those types of things are completely unanswered.
Yeah, I agree. And so, but coming back to the pain symptoms, patients take nonsteroidal anti-inflammatories, but there's a lot of concern about opioids and patients taking other kinds of recreational drugs and so on to try to manage the pain. Where are we in understanding the relationship between pain and lesions and managing pain and, what are the frontiers? How do you see this as partnering? Is this a place where we need multidisciplinary research? Maybe our, McGovern Institute, Pickhour should be kind of teaming up with CGR to think about this pain. What do you think the real challenges are there? No, we'll come back. We're going to come back. We're going to come back to the social stuff in just a minute here. We're almost, so Naya, do you want to?
I can't speak to the exact intersection between MIT and the clinicians on this, but I think that within medicine, we're trying to do a better job to understand pain pathways in terms of like centralized pain, all different types of pain and how it integrates into the pelvis. I know that a lot of anesthesia colleagues are doing a lot of research. We have some specialists now, in addition to gynecology becoming more specialized. I think our anesthesia colleagues are also becoming more specialized, and some of them are specializing in chronic pain, and actually working hand as a part of that multidisciplinary team to help to manage our patients with pain.
These multidisciplinary teams are becoming more of a theme. And Stacy, do you want to maybe comment on the work that Susie Asani and others are doing?
Absolutely. So I was going to add, work of Christine Seberg and Susie Asani, Dan Claw, that is now taking pain understanding, pain mechanisms, pain treatment, long-term coping and remediation from other pain understanding, which is also fairly understudied. That, again, pain is something that you have to believe someone else is experiencing. You can't see it. There are experts who are now working in imaging and brain imaging and MRI and seeing changes associated with pain remediation and treatment response. But that's a whole world where the multidisciplinary necessity is really infinite for what we'll discover next, but again, needs focus and funding and the development of those multidisciplinary teams.
So part of the pain, and it came up in the movie and it comes up in real life, is a societal tendency, the medical profession tendency, in some cases to not believe patients in pain, but also people not believing other people. And maybe, Chris, you have some insight into this. Like we had signs earlier today marching around Killian Court saying in period privilege, women who dismiss other women's pain. Can you speak to any of these issues that, because you're out there, we're kind of in a bubble here at MIT, and you see more of the real world and has too many other people who see patients and so on, but can you speak to some of these issues and how you think we can address them?
Yeah, thanks for giving me a chance to comment, because of course the social shoots through the biomedical, right? We can't separate them, but often when we talk about issues, we do separate them as if they can be distinguished. For me, what I love so much about Shannon's film is how it centralizes this message. Trust women, believe women, listen to women. And if we don't do that, then we will not identify the funding, we will not create the kinds of infrastructures of knowledge and practice that will really move the needle. So, pain. Well, pain, the denial of pain is something that we are, as women, socialized to do, to buck up and move on. That's rooted also in a sort of trenchant and enduring what I call menstrual illiteracy, where we don't really understand to read the body, the menstrual body, and more generally the body. So we don't understand what baseline normal is. We often hear that periods are painful. That's Eve's curse, right? You're supposed to suffer. And so how people understand their menstrual pain really depends on what they've been taught, how much is normal. So there's an awful lot of buck-upness that sort of perpetuates this system. And of course, medical practitioners are also socialized often to be suspicious of pain claims, and that's embedded in the long-standing patient-doctor relationship, which is intensely hierarchical. So there's a lot of destabilization of assumptions that needs to happen in order to really make an intervention here. It not only with ourselves and taking ourselves seriously and taking one another seriously, but challenging the medical system in the assumptions it makes about what's meritorious of attention, diagnosis, and treatment.
Fantastic. That resonates so strongly, I think, with so many people in the room. Another facet, you know, I have people, I'm at MIT and everybody's supposed to start a company. I get emails from people who want to invest in femtech, you know, let's start a company. And maybe, Tavneet, you could talk a little bit about innovation and, you know, Tavneet's at the Sloan School, and, you know, maybe a couple of things. One, innovation and how we go from where we are to any of this innovation and gaps, because I know you are familiar with this, but also across different kinds of cultures, because you're a specialist in Africa, and how do you see what we do in the US and then translating any of these things into places where there are lower resources?
Yeah, great, thanks, Linda. Can everybody hear me okay? Yeah, good. As long as I get thumbs up at the back, that's good. So thanks. I think on the innovation side, it just seems, and I think this comes out in the movie as well, that the research infrastructure is just really lagging, both kind of at universities as well as through the funding mechanisms. And I think that's probably constraining a ton of innovation and entrepreneurship around that. I mean, you can do femtech, but if I don't know how to treat this, what do I do femtech on? Yeah. And as Dr. Isaacson pointed out, surgery is not the option. You need to understand the disease better to find better treatments, and that's going to cost you money and infrastructure. So I think that's one piece of it. On the international piece, I mean, I work in a part of the world where we don't even diagnose diabetes, let alone endometriosis. So, you know, I couldn't even take a guess at how many people have it. My mom's actually a GP, and I grew up in Nairobi, and my mom's a GP in Nairobi. And when I got diagnosed, she was like, I haven't even heard of this. And I was like, hang on, you're a doctor. How have you not heard of it? And it's because she was like, when I trained, no one taught us about it. So I'm guessing there's plenty out there. I don't think there's anybody diagnosing it, let alone treating it. Certainly not surgical treatments that we've heard of. So, you know, I think there's a very long way to go before you solve it globally, let alone here.
Well, Keith, you spent some time in Rwanda, I know. So.
A couple of things. So we've put on programs not only in Rwanda, where there are some excellent surgeons, there's just low resources, as well as in Nigeria. We just had the endometriosis conference there.
Yeah, we were in that conference.
And we put on an endometriosis conference in Sri Lanka. So there is awareness from these physicians. I think they lack the resources for the surgery and for the treatment because, again, you can suspect endometriosis based on symptoms, but until you actually look with a laparoscope, it's impossible to prove that's what's going on. So it's more the funding, but the docs are out there, and they're really, really good surgeons. They just don't have the resources to treat the patients.
And yet the prevalence in other countries is similar to in the US. Around the world, the prevalence, the published studies have said that it's similar. So your comments about the surgery really underscore the need for new medical therapies. And one of the things that strikes me is that we're seeing more and more diagnosis in certain communities in pediatric cases, but that still remains a huge challenge, in part because pediatric patients may have different primary symptoms that come to the attention of a clinician, GI symptoms, et cetera. What do you think is going to happen? You know, is there going to be a trend to seeing more pediatric diagnosis, and do you think that this is a key to potentially getting better therapies early on?
Nothing happens quickly, unfortunately. And so we've actually been having conferences with our pediatric department to make them aware and ask them, you know, for the patients, because they have no idea what's going on, and nor necessarily should they, and they're very frustrated, and the patients are frustrated. So we've asked them, when you have a patient with severe painful periods, call us, talk to us. Either we could see them or a nurse practitioner could see them, but get the treatment options and workup done early. So they don't have to suffer. Not, like I said, not because we're going to prevent a problem 20 years from now, but there's no reason for them to have to suffer, all throughout high school and college. So it's just awareness is what we're working on, but that unfortunately just takes a lot of time.
But we know that inflammatory processes are very different in adolescents. Their hormone profiles are different. So it stands to reason maybe they're going to need different therapies. And we haven't really, the reason the pediatric patient in this movie suffered so much, potentially because she's really got different processes going on, and we're treating her with drugs for adults because we don't understand the pediatric case. And so this is, again, one of the very interesting challenges. What causes endometriosis? What do we know about I'm interested in what people know about what causes endometriosis. Maybe Peter and Naya, you start as the vanguard here of things that you hear.
Sure. I mean, there's a few theories. I would say one of the most prevalent is involves reflux menstruation, so basically retrograde from the uterus through the fallopian tubes and then implantation in the pelvis. There's others that stem from just the basis of neurologic development in situ. There's the role of inflammation. There's really quite a few, but I think the most prevalent is the reflux menses.
So reflux menstrual tissue, the uterus contracts constitutively. Sometimes it contracts from the cervix up to the fundus and fluid goes this way. Other times it contracts the other way. And so we know that women do have some reflux. What do we really know about the amount of reflux? So there's other theories. Developmental is one theory more right than the others?
No, I think in medicine, whenever you have 5 theories, there's not one that's absolutely correct. So it's multifactorial. Obviously there's part that's genetic, there's part that's environmental, there's part that has to do with reflux, there's part that has to do possibly with some type of cellular metaplasia, something to do with, so I'm convinced there's not one etiology that's going to cause endometriosis and adenomyosis. It is clearly multifactorial. And again, with a lot of docs, and even some, unfortunately, or not unfortunately, some that you interviewed, Shannon, we're often wrong, but we're never in doubt. And so it's just, I think we're trying to educate docs to take the approach that you don't necessarily know everything. It's okay to say I don't know. It's okay to say these are theories, but I don't have the answer. And I think that really helps put the doc and the patient on a great working relationship where you can work together to try to improve quality of life. So it is important to eventually understand the etiology, but I would say as of right now, we didn't know any more than what we do when Sampson came up with that theory in 1928. So.
Yeah, and I think in context, we certainly spend a lot of time thinking about etiology, in part because you can imagine that if there's different causes, there may be different ways you would treat it to keep it from causing symptoms, even in a young patient. So these are things we want to study in the lab and try to replicate, but keeping an open mind that in any given patient, you can see evidence that there's maybe reflux or evidence that maybe it actually burrowed through the myometrium. And I've become more convinced after seeing some movies we've made recently in the lab that there could be even just the endometrium just moving right through the uterus. I never would have believed that 3 years ago, but now we have the movies, and the endometrium is just crazy. You want to study something really crazy, come study the endometrium. So we also talked some about new therapies, and what are some of the challenges there have been some potential new non-hormonal therapies proposed. What are the challenges in getting them into the clinic, actually? What have you've seen things try to go into the clinic and they haven't quite made it? A lot of Me Too therapies, a lot of the drugs that cause menopause. The patient in the movie took one of these drugs, GnRH, either agonist or antagonist, with adding back a little estrogen. It's really hard to get it right. What are the challenges in getting things in the clinic? Maybe, I don't know, Stacy, we were going to have someone in drug development here, but he's not here tonight. So
well, I mean, and I'll comment from the research side, and then the clinicians can comment on that then transition, is that again, because we don't really understand etiology, we don't understand prognosis, so exploring novel pathways has only recently emerged, that, you know, reappropriating drugs that have been used for other conditions that in animal models and others are being shown to have some effect. Also, AI and machine learning and agnostic approaches that are identifying novel pathways. Again, Karina Zondervan's team recently published on a really elegant series of experiments that showed that you know, there's a novel non-hormonal neuropeptide S receptor 1 in a pathway that is involved in inflammatory responses. It may be a novel pathway to target. But, you know, part of the discovery, again, is having the data. One of the difficulties, again, with AI or machine learning and these large databases that are available for many other conditions and symptoms is that endometriosis, adenomyosis certainly is underdocumented, but pain and pain response and pain progression is almost never adequately documented in a way that can be pulled out of medical databases and things like that. And so that focusing on and pressuring for adequate documentation, and then again, bringing the multidisciplinary minds thinking in novel pathways is really extremely critical.
Yeah, just to expand on that, it takes a long time to get healthcare providers to change what they're comfortable doing. And we haven't had a new medication FDA approved for endometriosis that's, I think, that's been non-hormonal. And so we've just got it focused in our mind for the last 30, 40 years. We have to treat this by altering the hormones. And you heard beautifully in the documentary, you do that. There are side effects by altering hormones. And so we have to look at it, and that's one of the reasons I came to Linda. I said, we need a fresh approach. We need to say, okay, can we look at the inflammatory pathways? Can we look at other non-hormonal therapies? And as of now, and obviously we can't do that. We need to get pharmaceutical companies to take an interest in looking at that. And I think that's going to be the pathway. The pharmaceutical companies are going to have to realize that there is a good market opportunity for them to invest in the research, and that it will be a successful medication if we can get a non-hormonal therapy for this condition.
One of the barriers, I'll just follow up on the pharma companies, we've said the animal models, things work in the animal models and then they fail in the clinic. So there's a now loss of confidence in the animal models. And this is one of the things that we get pressured at MIT to do more and more. It's build the patient avatars that actually will predict how classes of patients will respond to the drug. So this is one of the things, imagine if we had a core facility at MIT, not just for endometriosis, but human patient avatars that had little immune systems. And this is one of the things we would love for MIT to invest in, because we really need it for female diseases, endometriosis and beyond, because they are chronic inflammatory diseases, and all we're doing now is manipulating hormones over and over again, and we know the definition of madness is to keep doing the same thing and expecting it to work, and it's not going to happen, so we really want to do that. We are getting close to the end of the hour for our panel. We were respectful of people's time. And we haven't taken questions from the audience, partly because we wanted to make sure that everybody on the panel got to bring out some additional points about the science and the landscape. If there are points that we haven't covered that panel members feel like they'd like to comment on, why don't we go ahead and do that now? And then we could maybe take, I think, if there's anything that any of the clinicians, particularly from MIT Medical, who came here, because we have a lot of students, and it would be good to hear any questions that MIT Medical staff who are here tonight have for our panel. I think we could end there. So first, the panel, is there anything that you wanted to comment on, any of you, that you feel we overlooked in trying to bring some additional illumination to this topic from the perspective of science and society? Yeah, go ahead, Chris.
I really appreciated Keith's point about we have to encourage providers to be more curious. And what I found in the field of critical menstruation studies is that menstrual stigma is a really powerful foil to curiosity. So we foreclose conversation, we foreclose information seeking and support around our periods and an entire menstrual cycle, which is a 4-phase cycle, and it impacts multiple body systems. So what happens is, because we're not curious about the menstrual cycle, many menstruators are very keen to suppress their periods, and not understanding that the side effects can be far-reaching and can endure for quite a time. So it's not surprising to me that not only are providers keen to suppress menstruation as a first-line treatment, but that patients themselves are very comfortable with that because they're not curious about their menstruation. And I'm not hating on the patients, I'm hating on the system that suppresses the curiosity, that allows us to really understand how our body systems work and how they confer lots of benefits beyond the ones that are obvious. So I guess what my point is we need to be curious, all of us.
I think that's a fantastic note to end on, and I really am grateful to you for bringing that up, because curiosity about menstruation and function of the uterus could lead us into amazing places, because the uterus does this amazing scarless healing every month. It's remarkable. The immunology of the uterus, it's wild. We can learn so much about immunology in general from the immunology of the uterus. There are stem cells in menstrual blood that people are trying to use for regenerative medicine. So we may be able to think about learning things that will help us heal broken hearts, for example. You get this beautiful angiogenesis and repair with no scarring. I think there's so many lessons we could learn scientifically that would impact other disease areas if we were more focused on unraveling the mysteries of the uterus. Yeah.
Hi, is it okay if I ask a question?
Just real quick, yeah.
So I am a pediatrician. I'm actually probably the longest slow fellow ever because I'm on medical leave for a lot of these issues. And I have been a medical director of the Medicaid program. What I would like to say is that the overturn of Roe v. Wade also very much impacts this, because there's a lot of fear around litigation. And to your point about curiosity, there's also a lot of suppression of sexual education in schools and in America in general. So we're suppressing curiosity and putting a lot of stigma into children's minds very early. And I think when it comes to social media, I think it's really important. There's a lot of potential big data scraping we could gather, a lot of crowdsourcing. There's also going to be a lot of policing that happens, and that's already starting. So I think we have to be very cognizant of how women's health and anybody who menstruates is being policed.
Okay, this is a good point to make. I think coming back to the curiosity, if we were able, in a fantasy world, I imagine the day when no one ever actually needs to get an abortion, because we have so perfectly understood the uterus that a woman controls when she gets pregnant. She doesn't have problems with it. The pregnancies go well because we don't have complications that lead to preterm birth, preeclampsia, and all these things. And, I'm an optimist and kind of naive, and I believe that if we all work together, we can't control necessarily the politics of the world, and we don't live in your world, but at MIT, we can pull together to keep that North Star of, if we could really understand the uterus and build the kinds of drugs that would let you control when and where you get pregnant, then maybe we could reach that. And so as scientists, our contributions can be to really help us understand this mysterious process, because endometriosis starts with menstruation, and many other things do too, and many other things that negatively affect women's lives. So I'd like to kind of leave it on that note, that we can share a common goal across political differences, that we would love to just bit by bit eliminate any need for ending a pregnancy and thereby bringing less stigma around the natural ways that we control, or the ways that we control medical issues with the uterus. And I know that may sound a little naive, but I have to keep my life organized around that goal of trying to bring more science in so that we have more options to prevent us from having to do that. So we're really at the end of the hour. I want to end the night, though, on one acknowledgement. There's a very, very special person here tonight, Dr. Annie Liao, and she wants to hide over here in the corner because she's very quiet, but she's a force of nature. She diagnosed me with endometriosis. I'd never heard of it, and she's taken care of me since 1988, seen me through a lot of stuff, and she is an enormous resource to the MIT community because she believes patients. She calls patients all hours of the night and day to tell them, eat your fresh fruit, all the things, even back in the day, she knew that fiber, gut microbiome, she was early on the gut microbiome, all of these things that really make the life of the patient easier. And the final thing I'll say, and I urge everyone, you brought up some sticky social issues. I'll bring up one more because every one of you may know someone with one of these diseases, and the patients in the movie had very supportive families and friends, but other patients are in abusive relationships where the spouse will demand sex and it's impossible to have it, where actual physical violence may happen because of the pain and not being able to carry out normal household functions and things. And it's more common than you might think, even in our MIT community. So be aware of your friends and your family because they could be in relationships where someone's really hiding stuff beneath the surface and they're really, really in need and maybe considering ending their own lives. And I urge you to just be aware and help people take away the stigma because there still is so much stigma. So thanks to our fabulous panel and thanks to Shannon and her team and you all for being so supportive.
Thanks to Linda, Susan, the whole team who put this together. You guys, so much work. Really, they were phenomenal collaborators. Thank you so much for everything.
Right.
Thank you for your time and your expertise.